So welcome to the webinar, Bridging the Gap Between Labs and Clinics. The lecture will be presented by Yen Pinheiro, RDA, CDD, and Kelly Bevington, and we will begin shortly. And with that, it is my honor to introduce our guest speakers this evening. First up is Yen Pinheiro, RDA, CDD. She is Dexis iOS Solution Specialist. Yen is helping dental teams confidently adopt dental technology, and with 30 plus years chairside experience, along with 20 plus years in digital dentistry and intraoral scanning, she makes workflows practical, efficient, and achievable, bringing clinical reality with modern innovation. And then our very own NDX, Kelly Bevington, Director of Intraoral Technology. Kelly began her career with more than 20 years ago as an RDA EFDA, graduating from Bryman College. She has a comprehensive knowledge of dentistry and the dental laboratory industry. She is professionally trained on most major devices, and she also is able to provide chairside coaching. She manages the NDX clinical iOS training team and has clinically trained over 1,000 dentists and their teams. She enjoys sharing her knowledge by presenting webinars and is a regular contributor to dental publications. And with that, it is my pleasure that I get to say, take it away, ladies.
All right, here we go.
So these are, thank you again for being here. As Jessica mentioned, we realize you have a plethora of choices for continuing education and learning opportunities, and we're thrilled that you chose to spend some time with us this evening. As a disclosure, neither Yen nor myself are being compensated outside of the respective companies that we work for, NDX and Envista. Nor are there any additional commercial supports from any manufacturing companies as well. So let's review a little bit what you signed up for, right? Sometimes I know for myself, I sign up for a lot of webinars and I'm not 100% certain which one it was this evening. So we're going to talk about core functions in the digital workflow and roles in transmitting the clinical data from the scanner to the dental laboratory. Yen is going to demonstrate some software that allows you to verify your actual scan. As an example, your occlusal clearance, or perhaps the draw for a crown on your crown prep. I think you'll find that part really interesting. And then we're going to also discuss what it takes to actually acquire a clear scan and good data and organized communication to the laboratory. This is really going to be an opportunity to bridge the gap, right, between the clinical dentistry that you're performing and getting that information to the lab itself. And then lastly, how best to assess the scans that you have already taken, and not just, to assess them and look at them, but really learn how to determine if they are accurate and will be successful for fabrication. And these are techniques that are being presented for educational purposes only. So let's talk about the foundational part of it first. And I like to joke that proper isolation, and Yen, I think we had a chuckle over this, right? Like, proper isolation is really critical. Technology is amazing, and it's come a long way in the last 15 to 20 years that it's existed, but it is not ultrasound technology yet. The camera does not look through saliva. It does not look through blood or tissue tags. So it's our responsibility to make sure that we have a clear, dry field and that the camera can pick up the margin itself. 360 degrees, not 180, and have the lab guesstimate at the rest of it, right? We want to see that margin 360 degrees. And it's important that there are never any holes or missing information in an area that it's critical to the fabrication of that prosthesis, right? So occlusals always have to be acquired. The prep itself always has to be acquired. The interproximal contact walls of a prep always have to be acquired. But if you're missing, a little papilla area on the opposite side of the arch or the distal of the second molars, not a big deal because it's not impactful to the fabrication of that crown per se. And lastly is exposing the margin. How best do we expose that margin? And we're going to give you some examples as to how to achieve that. This is a handout that is associated with this program that you will receive as a key based on some of the information that I'm going to review next. Basic crown preparation. So for the most part, we're doing full contour zirconia, but there's still PFM out there. And it's important to know the difference in the preparation styles and what we've experienced to be best practices at the lab. There is differences in opinion as far as a shoulder chamfer or a feather edge, a knife edge. Personally, I prefer a chamfer or a shoulder. I'm not necessarily a fan of a bevel unless it's clearly communicated to the lab. Oftentimes what can happen with a bevel is if there's the little tail of the bevel is misinterpreted by the lab. And so you might get crowns back that have short margins or open margins. It's because they didn't know that your bevel was there. It didn't show up clear enough in that digital scan. And then knife edge or feather edge, just tucked subjectively, probably my least favorite crown prep, but it's still workable as long as you can expose that margin. And how might we expose it? We're going to look at a couple alternatives in how to do that, a couple options. And before we expose that margin, how do we keep the area dry, right? How do we keep a clear view? So the two images on the bottom are lip and cheek retractors. The one to the right is called Optergate, and that's single usage and throwaway, right? I very much like it. It's great for people that are new to scanning. It just sort of opens up the field so they can see a little bit better. The one to the left, I'm sorry, backwards. I'm backwards. The Optergate is the one to the left. The one to the right is Comfort View. Comfort View is autoclavable. So it's reusable. If being green is important to you, that's a really nice option. The instrument, the gray instrument is called ScanMate. ScanMate works very nicely. We were talking about some procedures I was working with earlier today. And it's a retraction tool, right? So it's going to retract a lip, a tongue, really nice for tongues, but so is a tongue depressor. So is a plastic mirror when you're using four-handed dentistry. And I would encourage you to use one of those. It really helps. Sometimes with the scanner, you can use the wand itself to retract the lips and cheeks and tongues, and other times it's a little more challenging. And then the NeoDry dry angles, they're probably the most favorite thing I use. I like to put them on the inside of the cheek against a parotid gland, and it's not mirrored on the backside, and the scanner slides very nicely against it. Oftentimes I find with some patients that when you're scanning them and you're retracting the cheek frequently, it almost milks that parotid gland, and all of a sudden you have a lot of saliva on the mandibular arch. Bite registration, super important. We always want to make sure that our occlusion is as accurate as possible. What's really nice is most all of the scanners today have some sort of occlusal clearance guidance tool, which is wonderful. I'm still a bit of the philosophy that we should always check ourselves to verify that the occlusal reduction is appropriate before taking an impression, whether it be an analog impression or a digital impression. So some people like to use their eyeballs, right? I'm not a big of a fan of that, Maxillary second molar, good luck. That's going to be a hard one to see. The image that you see on the screen is called Prep Check. It's one of my favorite tools. It is a little boomerang shape. You place it over the prep itself. You have the patient tap, 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 and it is going to leave a mark on the prep if there is not adequate clearance, very similar to articulation paper. And then you know exactly where you can go back and remove that excess tooth structure before you ever start to scan. You could also have the patient bite into a piece of wax and measure it with calipers, or your dental assistant always knows if he or she is making the temp ahead of time, whether there is enough clearance or not. So just a couple things to keep in mind for an optimal scan. So again, super important to make certain that the margin is exposed, that 360 degrees that we talked about. Personally, I'm a double cord fan. That is my favorite gingival tissue retraction technique. Here's an image that gives you a good idea of what that exposed margin should look like. Very nice and dry. And again, I mentioned I'm a cord person. I like a dual cord, honestly. Probably a double zero cut to the exact circumference of the tooth itself, of the prep itself, tucked subgingivally, followed by maybe a number one. The number one could have the tails out. In addition to that, I'm going to have the patient bite into something called a compricap. Excuse me. And use a hemostatic agent. I really always have a hemostatic agent available. Oftentimes there's a little bleeder that pops up. One of my favorites is from Ultradent, and it is called Viscostat. It has a nice little sponge applicator. You could also use Hemodent, and there's, generic brands as well, but you can just burnish it right in onto the tissue where that little bleeder is and create hemostasis. Now, there will be people that say, Kelly, I haven't packed cord since dental school, and I have no intention of ever packing cord again. And that's fine. There's always different ways to achieve great results. Retraction paste or foam cord is another really good tool. The trick is really being educated on how best to use it. So the retraction paste typically either has a really fine tip to it that you can express the material into the sulcus, but it's hard to express it, right? Or it's easy to express it, but it's sort of thick and it doesn't really go into the sulcus well. At which time I will use a compricap in combination with that. But I think it's important to make sure that whoever is using the material is well educated on that it really needs to be expressed into the sulcus, because then it's going to puff out and swell a bit, and that's what is pushing the tissue away from the prep itself. Oftentimes I experience uneducated people just placing the material on the gingival tissue, and it works great as a hemostatic agent, but it needs to do more than that, right? It needs to retract that tissue away from the prep. Can laser be used? Absolutely. Laser works really well with digital scans. Just be conscious of the settings on the laser itself. Sometimes I find that it shows up more like electrosurge. You know, there will be like little mountains of gingival tissue that has been a bit charred. So I'm not sure if it's the tip that was used or the setting that was used, but just be conscious of that the first time trying to use laser to remove some of that gingival tissue. There is another technique out there referred to as rotary curettage that many dentists that I've run into like to use. It's taking a burr and physically removing the necrotic tissue around the prep itself. They like to do that because the tissue in 2 weeks will be, growing back nice and healthy. And that is true. However, getting a good scan can really be a bear sometimes. So be prepared with appropriate hemostatic agents to help reduce the bleeding if that's a technique that you like to use.
Are we ready, Kelly? We're ready?
Yeah.
Let's do it. So, bridging the gap between labs and clinics. It all starts with a scan. All right. So, we have the ability to do common scan and prep scan. We can do a quadrant scan. We can do a full scan. Do whatever you want to do. Why would we want a common scan? So, a common scan is a scan that we would collect right before we do any changes to the tooth before we prep it. It allows us to have something, data, to reference back on what was in the mouth when the patient sat down. It can also help us when the lab fabricates the crown or restoration and biocopy any of the data from the existing, the prior to the changes that we made. So what was already in the mouth before we prepped it. But one of the best scenarios, Kelly, and I don't know if you experienced, I'm sure you've done it plenty of times, where how you have a partial, here we go, you have rest seats, or you have class, right? What always happens? We get decay. It's always on the gum line. We get decay. So we have to destroy this crown, or, re-prep and go ahead and take another impression. Well, back in the days, we'd have to take away the person's partial, and it was such hard because it'd be gone for a couple weeks. But today now, if we had that common scan, we got great data of what was there. The lab can biocopy. So when that patient comes back and we put that crown in their mouth, those rest seats, those clasps will fit seamlessly like a puzzle piece. But the reality is there's times when we just don't have time to do a common scan. Or there's practices that just don't want to. They just want to do a prep and they want to do a posing and a bite, and that's okay. But do know there's different options and different scenarios.
And truly, the more information that you can provide the lab with a common scan or a pre-preparation scan, the better, right? The more information, the better for the laboratory.
Oh, yeah. Yeah. And, back in the days, remember when we started with 3 and then half a mouth? And then we got brave. We went to the canine.
Yeah.
And now we're just doing the full mouth because it is that quick.
It is that quick. Yeah.
Yeah. So we're seeing it more than ever. So what happens after we collect our data, right? We're going to go ahead and want to check for post-process, the upper, the low, and the bite. But what if you was not sure that the prep was as clean or what was going to look like after we checked a post-process? Well, within the software, there's a button that we call highlight. And what would that do? That button will allow you to just process one area of the mouth in about 3 seconds, so you could be certain that you're ready to move forward. We also have the ability to check for undercuts. That can just tell us where it might need to be blocked when the lab fabricates. Or if nothing else, it allows us to see our preps in such a big magnitude, and we can improve if we wanted to because we see where the undercuts are. Let's go ahead and see that in action. So right now, you're going to see it's going to go ahead, select an area. On the right side, it shows you what the final results will be like, what the lab sees. We're going to go ahead and check for undercuts now. And the red indicates where the undercuts are. And if you want it, you can also take a picture for the lab. And a quick reminder that everything we do within the software will carry to the lab. So there's no need, it went ahead. So there's no need to go ahead and attach any data. So there's another scan tool in the software where you can see the heat map and how the patient occludes and the distance between the teeth. You can even truly measure and see how much clearance you have. So you can be certain that you have enough reduction or clearance for the restoration that you're making. You can also screenshot that for the lab. Image gallery. So within our software, we have the ability to collect images. We have the option of using it as a camera. You can just pick it up and take a picture of the prep or take a picture of anything else that you want to share. We also have snapshot, which takes a picture of the whole entire screen. It's just the same thing that we do with our cell phones. But we do have a powerful tool called Intraoral. And what does that allow us to do? Wherever we click on the mouth, anywhere we click will give us 9 images in a little bit of a different angle. And then whatever we star will be saved. That will go back into the chart and will be also transferred to the lab. So what if the patient was out of the chair and gone, and you needed to go back and get a picture of the tooth before you prepped it? They require it, they want it. Or had you had a common scan, the patient was gone, you can go back into your case and go ahead and collect that image from that medical record. Let's see that in action. Camera, 3 images that I took. We're going to change the view. And now you have the 9 images. We start on the one that we like. And as we click throughout the mouth, it should give us options. Resolution and bite. Kelly, do you get this all the time? Oh, what should it be? You know, how should I refine? There's so many options. It gets so confusing.
It can. It can be really confusing.
It can be confusing. So let's talk about that. So when we talk about restorative dentistry, I like to either use basic or optimal bite. That's a preference. Basic means when the patient bit down, that's it. Don't touch it. Optimal means when the patient bit down and the software thinks that it was a little bit off, it might make a slight adjustment that would optimize the bite. Options. Refine resolution. For restorative dentistry, I like to see high or super high. What is the difference? High is the way that everybody goes. Super high is when you need a little bit more help because it was a more challenging case and you just want a really high resolution. Do know the higher the resolution, it might take a little bit longer to process the scan, but that's okay, right? So case specific, the best thing to do is to try both options and see what it actually looks like so that you can make an educated decision and see with your eyes how it changes from high to super high. Now, as far as the mesh rendering, I'm a big fan of high def. Everything for me is high def, all the way, high def 3D. It's no different than when I watch TV, Kelly, I'm not gonna lie. If I had an option of regular TV or high definition. Matter of fact, my choices are always gonna be high def, never regular. We don't do that anymore, right? Mm-hmm. So within the software and scanner, you can also do a smart shade report and a manual shade report. Kelly, what does the lab think about all these scanners out there that can take shades and stuff like that?
Yeah. I'm going to say it's not foolproof at this time, and that there's a lot of considerations with your environment right? Like, back in the day, I remember I was the assistant, and these fuchsia bibs, right? Patient napkins came out, and they
Mhm.
were gorgeous. And so I ordered them, and I'm all excited. And all of a sudden, the shades on our restorations were coming back not right, And we identified it as being this crazy shade of a patient napkin. There's a reason why they're typically baby blue or a cream color. It's because it's more neutral when looking at the patient and selecting that shade. So I would say that the lab in general still likes a physically taken shade as well, like provide this, right? And also provide the shade from the, 3D Shade Master, Vita, or whatever your shade guide is, and send it all, right? I like to encourage the doctor to do that chair side and see how it compares to what they saw with their eye versus what the scanner picked up.
Right. Yeah. Do you remember when we used to take the patient off the chair? We would grab the shade tabs. We're
Yeah.
walking them room to room in different
Yeah. Take
lighting
them
to
out in the
match that
parking
shade.
lot. I mean, yeah.
Oh, yeah. Yeah.
And get the fancy light bulbs for the operatories. And yeah, I mean, taking shade can be really tricky. And for some patients, it's more challenging than others.
So how do we do it in the digital world? So just like I said, that we would walk our patient from different lighting to pick a tab within the software. If we use the Smart Shade Report, what it is when we collect the data with the scanner in the mouth as we scan, and as we wave the scanner in different wavelengths and angles, that's the same thing as in the analog world where we would walk the patient from room to room. So the distances and the light reflection and different angles is how we do shade collection in the digital world. What the software will always do is it'll give you three shades: a cervical, a body, and then an incisal. But I always tell all the customers and that the scanner and the shade report is a first set of eyes to help you pick a tab, but you should always verify with your own eyes. And you also have the ability to modify what the software picks for you. There's also the manual shade report, and that's important to see. And the reason why is because although the software might have picked these three shades, depending on where you point on your tooth, it could be a plethora of shades because the reality is, Kelly, teeth are multiple shades. They're
Yeah.
multiple shades. So just where do we point at that moment?
Mhm.
But I have a trivia question for you that I love. I always ask, scanning so much throughout the years, my high end restorative work is always a D2 on the insides of edges. I think that's a wonderful shade. It's so translucent, so lifelike. It's always a D2. The really nice work. Mhm. Thoughts? Yeah, you agree?
I can go with that. I can go
Yeah,
with that.
yeah, yeah. I would scan after they're done. I'm like, oh, that's a beautiful D2 on the inside. So I'm good with that. Yeah, yeah, yeah. All right, let's see it in action. So that's the Smart Shade Report. It's going to give you the three cervical, body, and incisal. You're welcome to modify it, right? It's basically first set of eyes, pull out the tabs. This is what we think it should be. And from there, you will go ahead and examine, right? But as you can see, we can modify. You can do that. But let's show you how to do a manual. And that's so important because that's when we truly can appreciate, oh, by the way, we just saved that. So it's going right to the lab. You don't even have to write in the lab script. But here's the manual shade. And watch as we move that cursor around that occlusal table. This is the last crown that I made in the clinic for this model. It was my last crown. It's beat down now, but it was the last crown that I made in the clinic. And then as we go from the buckle, you can still see all the damage, the life that crown has lived in my bag, right? As part of my demo. But anyways, as you can see, as we move the cursor around, teeth are so many different shades. Oh boy, the margin line. If you want to draw your margin, you can. You can. Most clinicians just send to the lab and the lab draws the margin. Kelly, what are your thoughts on that?
There are, I'm going to say a smaller percentage of doctors, maybe 10%, that routinely mark their margins. That's important to them. They're good at it. They're accustomed to it. Perhaps they were trained with, usually they were CERAC users or introduced to digital technology and did same-day dentistry or design, perhaps even in dental school. And they really gravitated towards that and they like that.
Yeah.
But for the
Yeah.
rest of the dentists, I think they struggle at marking the margin. Sometimes they want to mark the margin on a case that they perceived as a little more challenging to either fully expose the margin or keep it level 360 degrees. It might have a little step in it, and they want to communicate that to us, or there was a bifurcation or something that they want to communicate to us. I would almost rather them communicate that separately on the script versus trying to mark the margin. What we see a lot is that it looks marked from the occlusal, and then in the design software, when you move it to the lingual or the buccal, it's completely off, like completely off. And so, the doctor wants you to use the marked margin, but it's off. So then we go back and forth in communicating about that. And it's almost like, I'm old, but back in the day, there were prosthodontists and dentists that would have the lab pour the models and send the model back to the office because the doctor wanted to trim and ditch the dies, trim the dies. And people really don't do that anymore. And they don't, in my mind, that's what it is digitally, is a doctor ditching and trimming their own dies. So my take is stay with what you're good at, right? The dentists are great at cutting the teeth, at prepping the teeth, and the lab technicians are great at marking the margins. And that's what I would stick with.
Yeah. And here's the thing. I heard you loud and clear. Send us some pictures, send us some data. So within the software scanner, we can go ahead and use the image gallery and extract an image from the raw data from different angles. Again, it will attach to the lab. It would attach to the lab slip. So when the lab gets it, they can use those images to help them detect the margin.
Yeah.
Would that be helpful?
Absolutely.
Yeah.
Absolutely.
Yeah. All right. Let's see them mark their margin. So the software is going to allow them to do one complete loop with the software. And then you're going to blow it up and you're going to refine your margin. And after that, you would take a screenshot and it's going to, again, go straight to the lab. No attachment. Everything you do within your software will go to the lab. As you hover over each of those tools, it reads it for you. So if you forget what they do, it'll tell you what it does. And there you see, we're going to refine that margin in that area. And when we hit the end and we're ready to save it, we're going to double click and it's going to redraw that margin on that distal. There you go. Go ahead and take a screenshot of that. Send that to the lab. And again, we can do different angles.
Love it.
Don't underestimate this image right here. An image is so powerful. We all have patients that refuse x-rays. They refuse. We have them sign off. We have them whatever. But what if an insurance company comes at you and says, why did you not take an x-ray? There is a code, I believe, Kelly, that you can use for images or pictures. But what this allows you to do is to show the whoever's asking, insurance company, anybody, that I do have a scan on my patient. We showed them the reasons why they should take an x-ray. We did the best we could. So this could be in lieu of when they don't want to take x-rays. You do have something to show when the information is needed. Does that make sense to you, Kelly?
It does. It makes a lot of sense.
Yeah. It also can create a report. And sometimes we do this even just to send to the patients. Some doctors just like to, have their name stamped on stuff and just show them what they can do within their software and scanner. Yeah. All right. I think we're done. No, almost done. So when we start to send the case to the lab, there's options, right? There's options how we can send stuff. We could always pick our lab and we can send it right to the lab. But there's so many other things we can do. We can generate a video for our patient of this scan. We can also generate the quadrant snapshot report of their mouth, and we can send that to our patients. Patients have never been able to see their mouth at this magnitude. And I think it's important that we allow them to be part of the diagnosis and treatment planning. Because when they can see their mouth like this, they own it and they truly understand what we're talking about.
I agree with you, Yen, and for anybody that knows me, they've heard this story before. But it really, really was impactful and hit home for me. And I like to share it with doctors who might not be using scans of their patients to really communicate to the patient about their oral health and about their condition in general. So the story is my husband had changed dentist. He goes to the new dentist who has a scanner. His previous dentist did not. They take a scan of him first. He has his teeth cleaned. They do x-rays. Doctor comes in for an exam. And instead of going over the x-rays, he pulls up the scan, right? Larger than life on the big screen, and reviews a couple items with my husband. One being number 14, who had which had a large MOD. So you see the gray area, that's an old amalgam, silver filling, and that black line through it is a fracture. And so every time you're biting, you're sort of spreading that tooth apart. We're recommending a crown on that tooth to help preserve the tooth structure. And you're like, oh, okay, yeah, that makes sense. Let's schedule it. Because, my last dentist told me, they've been telling me for a couple years I needed a crown on that tooth. But he showed me some x-rays, and I'm a helicopter mechanic. I don't know anything. I don't know how to read an x-ray. But the picture of his own mouth allowed him to hear the information, digest the information, and like you said, really own his own oral health.
Yeah, I have another scenario that's so funny. It's like we had a patient that had a scan, right, of their mouth, and then they had some work done, like a mesio of number 7 per se. They left the office, they went in the chair. What do they do? They lift it up and they look in the mirror in the car before they leave, right?
Oh, yeah. Yeah.
Well, that patient came back into the office. She said, the doctor chipped my tooth. Oh, yeah. The doctor chipped number 6 because that was not there when I came into the office until he did that filling right next to it.
And you could show them the scan, right?
We didn't chip your tooth.
Yeah.
Grinded your tooth. As a matter of fact, let's take a peek because I think this is so important for you to see. Do you see the scan that we have? It's not a chipped tooth. It's a wear facet. Remember how we asked you and we said we really need to get you a night guard? This is why.
This is why. Yeah.
And she looked at us, and we're not in trouble anymore because we did nothing wrong. But her next thing is, can you take an impression and make me a night guard right now? And that is so cute because we've been probably telling her that she needed a night guard for the last 20 years.
Oh my gosh. Wow.
Right? But until she's seen something and she made the decision, and now she told us she needed a night guard. Yeah. Yeah. All right, guys. Here's your quadrant snapshot report. It's going to be 2 pages, right? Email it, print it, use it for insurance, whatever you want. But don't underestimate the power of these images that we can collect from our software scanner. Oh boy, I'm going to throw a monkey wrench in there. Kelly, can you read my screen? I love it. Listen, we want you in the digital world, but there are times, and that's the reality, and we want to be transparent, right? Nothing is more important than being transparent. What about when you cannot collect that margin? I don't care if it's you had a bad day. I don't care if it was just the patient's on these medications that it just bleeds like a stuffed pig. Or, I really butchered it up. It was deep. I had to chase it. We're struggling. We packed cord. We did everything. We still can't see that margin. But in your mind, you know that some light body, traditional method is going to get the job done. So what are your options? Are you going to move everything aside and go analog? No. We're going to introduce one last tool before we close out the day, and it's called hybrid. Hybrid is when you know that you tried your best to collect in vivo, but there was one area that your scanner could not get, but you are certain that some nice light body can flow in and fill that gap for you. So what we do in the software is we're going to go ahead and utilize the data you have in vivo. That's perfect. But the spot that you see that's missing and we couldn't collect, we're going to fill that in by scanning the impression. And when we scan the impression, we go to the check page. It's going to spin its wheel, and it might take a little longer, but it's going to go ahead and merge that impression into your scan. So when you blow it up, you're going to see where the impression material filled in where we could not collect data in vitro. So what does that do? It keeps you in the digital world. Let's see it in action. We added the impression scan. We went to the prep page. There's that missing data. Right? We went to the impression page. We scanned the impression in. And then when we go to the refine page, it's going to build it and it's going to add it in for us. And you're going to see what it looks like. I left this wheel spinning because it's so cute. I always say, no matter what software we work with, whatever we do, the human is always going to be faster than the software. And I always try to remind everybody that. We're never going to really be sitting here watching it because really in real life, in the clinical setting, you're pitter-pattering and you're doing things in between. Let's look what it looks like. So there's the existing before we prepped. That's your scan of the prepped. And that lovely green on that mesio is where you couldn't get data in the mouth and the impression material filled it in. And we called it a hybrid impression scan.
So we have a couple questions on that.
Oh boy.
Yeah. So does it need to be can it be a triple tray? And then there's another question. Does it need to be a complete impression, or can it just be like a little like bite tab impression just of the prep itself? Like,
A
does it have
great
to
question.
have, I think it means, does it have to have the whole quadrant, like adjacent teeth?
No, we only have to take an impression of the area that's missing data. So we don't have to use a quadrant or full. We can just get 3 teeth. I always say 3 teeth just so that you can make sure that you got the middle, right? We don't want to be off. 3
Very
teeth.
good. 3 teeth. Okay.
Just 3 teeth. And what was the other question? Was there one more that if you had to do a
The
full?
first one was, could it be a triple tray? And then the
Yes,
next question
absolutely.
was, could it be like just a single little tooth, like on a bite
Yes,
tab, it says. I think it means like, how we'll take a preliminary impression for a temporary.
yes, yes. But you're going to need that light body in there. So you could do a regular tray or a triple tray. But you want to have that light body in there because that's the flowable part.
Got it. Yep.
Mhm. Any other questions out there, Kelly?
Not that I see. No.
All right. So we all know that you and I and everybody, most people on here, were all auxiliary. And technology made it possible, but it's the clinical team that will make it work. So I'm hoping that everybody grabs some great tools and tricks to help them in the digital world. And if you were happy with what we did today, we're going to do it again in the third series, and it's going to be implants and dentures. Thank you.
Thanks so much, Jan.
Get that little quick video for you guys. Got to show the video. Here's another little thing. If you send the video of the patient's mouth to their cell phone, I guarantee you, if you can watch them out the window, they're going to watch the quick little video, like a TikTok, a little Instagram reel before they start driving. Yeah.